Okay, great. I see it's hit the noon hour. My name is Shauna Moore, and I'd like to welcome everyone to today's Systems for Action and Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of our presentation is Improving Population and Clinical Health with Integrated Services and Decision Support. I'd like to go ahead and present the agenda for today's webinar. Again, my name is Shauna Moore, and I am the Dissemination Director for the Robert Wood Johnson Systems for Action National Coordinating Center. Our presentation will be by Dr. Joshua Vest, and our commentary will come from Dr. Glenn Mays. I'd like to go ahead and introduce the speaker for today. Dr. Joshua Vest is a health services researcher with interest in organizational determinants and effectiveness of health information technology and systems, specifically the adoption, utilization, and policy issues of technologies that facilitate the sharing of patient information between different organizations. As a former local public health practitioner, Dr. Vest has a particular interest in effective public health information systems, including the role of information technology governance structures on local public health departments' adoption of information technology systems, the structure of state and local public health information systems, as well as an evaluation of email intervention to improve disease notification efforts. And our commentary will come from Dr. Glenn Mays, who is the Director of the Systems for Action National Coordinating Center and is a Scotchfield Endowed Professor of Health Services and Systems Research at the University of Kentucky College of Public Health. He also serves as Director of the Center for Public Health Systems and Services Research within the College of Public Health and Associate Director of the Center for Health Services Research within the College of Medicine. Dr. Mays' research focuses on strategies for organizing and financing public health services, preventative care, and care management systems for underserved and high-risk populations. And without further ado, I'd like to go ahead and hand the program over to Dr. Vest.
Well, thank you. Go ahead and start my presentation here. So I appreciate the opportunity to talk to you all today about improving population and clinical health with integrated services and decision support. Of course, this work was funded by the Robert Wood Johnson Foundation through the Centers for Action National Coordinating Center. And I'm going to describe the activities we've been taking part with that grant mechanism. Before we begin, I have really like a cast of thousands to acknowledge and thanks, but most importantly, I need to acknowledge the work of my co-author and co-primary investigator, Dr. Paul Halverson, as well as Dr. Minikimi, Dr. Granthis, and Dr. Kanatsuri, who helped do all of this work that I'm primarily showing today. And for those who are interested, portions of this work have been published in Health Affairs, and others are in press at the American Journal of Preventive Medicine. The citations are below as well. So I think everybody is familiar with the idea that U.S. policy is moving to make providers more accountable for patient health. You know, that requires a change and new perspectives in the way of doing business and the way that healthcare organizations think. We're talking about upstream thinking. We're talking about a focus on prevention and also addressing social determinants of health. So moving beyond just the kind of clinical medical care model and really thinking about these factors. Now, in response to those kind of needs, more and more organizations are employing what we would say non-medical professionals, types of staff and experts who offer a variety of services, and we're going to call them all under the label of wraparound services. So people who help the care team, like social workers, behavioral health, dietitian, say pharmacy consults, financial counseling, patient navigators, medical legal partnership, all of these individuals wrap around the care providers and help give that kind of holistic addressing of care and needs that are both upstream and social determinants and very preventive in nature. And as I said, organizations are starting to employ more and more of these types of providers and staff. So what roles do they fulfill? Well, they're the ones who actually mostly address health behaviors, social contexts, and environments. These social determinants of health, as we know, are the biggest drivers of health care and medical care. And we also know that social determinants of health can inhibit care delivery. So this is how they work in partnership with medical care. Lack of transportation, poor social networks, low educational attainment all complicate or actually prevent care delivery. So they work in a complementary manner with the clinical care delivery team. And why we need to have these types of staff in organizations is clinicians are traditionally not trained to address these issues. And quite frankly, the healthcare system wasn't organized to address these issues. So we need to have specialized professionals to help fulfill those roles and address these needs. So our first research question that we're going to look at in this presentation is, does receipt of wraparound services reduce patients' healthcare utilization? And we're going to be considering all those things before as wraparound services. And the approach we took was we measured the association between wraparound services and utilization in an 11-year panel of adult patients. So I'll tell you a little bit about where we did our study. This is Eskenazi Health. It is a federally qualified health center with a hospital. It is the Indianapolis area safety net provider. They have expanded their wraparound services on a co-located basis beginning in 2011. So people like social workers, mental health, dietitians are all in their FQHC sites co-located. So when we talk about these services that patients will be getting, it's not external referrals. They're all internal to the organization. The sample included adults with primary care visits between 2006 and 2011, and to be in our panel, patients had to have one visit before or at least one visit after that kind of date that Eskenazi expanded their services. Now, our determinant of interest was receipt of wraparound services. To actually document that, there's a citation there for the International Journal of Medical Informatics where we go through and describe how we actually found and documented all of these services. So patients getting any social work, behavioral health, nutritional counseling, respiratory therapy, financial planning, medical legal partnership, navigation, or pharmacist consultation fit under this label of wraparound services. And these could be documented in notes, could be documented in the registration system, could be documented by billing codes, could be documented by orders. So it was a wide variety of places where we found these patients being referred to these services, but that's what we look at. And all patients in the study sample are going to receive at least one wraparound service during the study period. And we looked at two outcomes, annual hospitalizations and annual ED visits, as kind of your prototypical, easy to measure, and universally recognized outcome measures that would be of interest to many people. And so we control for other things and look at annual risk scores, utilization history. We have our receipt of a wraparound service. Those are all time varying per patient. And we also look at some chronic conditions and demographic factors, but those are going to be time invariant and less relevant to our modeling strategy. So our approach was we took a patient-level fixed effects Poisson regression model to describe the association between wraparound services and outcomes. So our patient-level fixed effects control for all the time invariant factors, so things like race, ethnicity, that don't change over time are automatically controlled because we're looking within patients. We included the time varying measures in the model, like the annualized risk score. We include year dummies to adjust for secular trends. And we use robust standard errors to adjust for cluster. Now we entered wraparound services as a lagged binary indicator, so what we're really looking at is association with subsequent year utilization. The year you got a wraparound service, what was your utilization like the years following that, is how we're actually modeling this out. And we do several robustness checks that I'm not going to detail today, but just simply report that we took them and tell you, what we found. We repeated it using a fixed effects with a negative binomial regression. We also did a propensity score match comparison group of patients who did not receive any wraparound services using a random intercept Poisson models as well. So here's just the overall demographics and comorbidities of our patient population. And as you can see, it is highly reflective of a urban safety net provider. We have a we have a very diverse patient population. We have a very high set of chronic condition prevalence, asthma, diabetes, hypertension, depression, all well above national averages as well. As you can see, it's, as I said, reflective of a safety net population. Now, when we just look to see what kind of wraparound services patients got, dietitians and social workers were the most commonly accessed wraparound services. Of all the patients who got services, nearly half of them were dietitian, nearly a third were social workers, about 10% got behavioral health, and then we have a mix of others. Nearly 7% of the population in our sample, our study sample, got multiple wraparound services together. But when we look at this, we're going to look at just globally any receipt of services. So when we do our regression models, we see that receipt of any wraparound service was associated with a lower count of hospitalization in the subsequent year, and that's shown by this beta coefficient here, negative, about 7% reduction in the expected count of hospitalizations. That's controlling for severity score and previous encounters in the year and the year dummies, which are not there just so things become more readable. Now, we also see that it was associated with a lower count of ED visits in the subsequent year too. Just extending the table out, you can see that again as well. We see about a 5% reduction in the expected number of counts of ED visits after a patient adopts the wraparound services, or gets the wraparound services is a better way to put it. Now, so far, there are a couple limitations to those findings. One, there's obviously a generalizability concern. This is a single safety net institution, and I mentioned this earlier, but this is very important both towards implementation and towards generalizability. All of these wraparound services were offered on a co-located basis. Organizations that use referrals to external or service providers for like social work or other services may not see similar results. But Eskenazi had all these folks in-house, which actually made referrals much more easy to identify, track, and actually know they occurred. Reductions could be attributable to other quality improvement activities occurring at the same time. This is a standard challenge with, I think all of us know, longitudinal healthcare studies that organizations and policies are continually tweaking and going off and on throughout the process, but there's nothing that we think necessarily should have been driving both hospitalizations and ED visits at the same time during our study. And results do not provide insights to the relative value of each service. Our data were not robust enough or large enough to be able to stratify out to know what was the contribution of each, or to look at stuff in a stratified manner. So overall, what did we see? Receipt of any wraparound service was associated with a 7% lower count of hospitalizations and a 5% lower count in the number of ED visits in the subsequent year. And so what can we take away from this? A portfolio of wraparound services may be an effective strategy for organizations serving complex patient populations, and wraparound services could complement health information exchange, risk stratification, or cross-sector collaborations very nicely. Health information data could support and inform who gets wraparound services and who's in need of them, or where patients go to get services. Likewise, risk stratification could help identify patients who need wraparound services, and cross-sector collaborations could actually provide more services than just a single institution could work with. So all of these things are opportunities to expand this concept of wraparound services that appear to be potentially effective in helping reduce some utilization. That, however, is our segue to our next portion of our work and study as part of this Robert Johnson Foundation project. So we move into and ask the question, how can we better support efficient and effective use of wraparound services? Now, if we think they're useful and we think they have potential value, how can we, help push a good thing along? If we believe, and actually several reviews in literature now starting to show this, that addressing social determinants and social factors are helpful to patients, how do we help push a good thing along and encourage more effective and efficient use of it? So what we do exactly now is what we suggested previously by trying to leverage health information exchange data and risk stratification to better identify those in need of wraparound services. So we have built a machine learning algorithm that ingests claims and EHR data. So that gives us utilization and diagnosis. We have linked it to multiple area-level resource data sets that describe living conditions, social context, safety, transportation. We've also linked it to multiple data sets describing the burden of disease and the types of health behaviors that patients experience and where they live. And we've linked it to health information exchange data, so we have a comprehensive view of encounters and behaviors from across the entire state of Indiana. The Indiana Network for Patient Care is the database that's operated by the Indiana Health Information Exchange, which was created here at the Regan Street Institute. It includes more than 110 hospitals across the state and has data going back to the 1990s. And so health behaviors and encounters from across the entire community for a very long time can be leveraged as well. So we have data that reflects behaviors, we have data that reflects the social determinants of health and area conditions, and clinical encounter information. We combine all of that into random forest machine learning algorithms that predict out the need for a referral to one of four conditions: any wraparound service, behavioral health, a dietitian, or a social work referral. I want to be very clear, one of the things that we are doing very purposefully here is we are not predicting need from a specific social determinant. We're not predicting a person has a high need for food insecurity. We're not predicting the patient has a high need for transportation barriers. That's not what we predict. We predict out whether or not you should be referred to a service. That is the outcome. The referral is the outcome. We do that under a couple of reasons. One, the referral is documented and we can use it in modeling, whereas need for social determinants is not always documented and we would require screening of every single patient to get that information. The second one is we want to be more actionable and fit into workflows. Providers in a primary care environment serving a safety net population know that patients have a lot of needs. They know that. That's not a secret to them. What they need to know is who they should be sending these patients to. That's what we try to fit with workflows better. And then lastly, social workers, dietitian, behavioral, they are all going to rescreen individuals anyway using their own tools and assessments to get more specific. So what we focus on is getting the patient to the right person. So our machine algorithms build that out. Our machine algorithms, we have a publication describing it in the Journal of the American Medical Association. It performs well. It does as good as many other diagnostic screening tools and fits within the range of what is considered clinically useful. but all those details are there. So how does this work? We've automated the process to provide risk stratification information every morning to Eskenazi Health providers. So before the clinics open, Eskenazi Health sends to us a listing of every single patient who is coming in that day. Comes over way early in the morning. Our machine learning algorithms and application takes that data, that list of patients, sends a call out to all the data sources I mentioned before, runs our machine learning algorithm, identifies risk scores, and sends them back in the form of a report to Eskenazi Health. Eskenazi Health providers, it's open to all providers, but our primary target audiences are those wraparound service providers and nurses who are specifically tasked with care coordination, but it's accessible to all the staff. It describes the patient and categorizes each one of their risks for needing a referral and shares out those scores. So before a single patient walks through the door at Eskenazi, when they do their morning huddles, every single wraparound service provider has access to this information. So they can help identify people who are in need and work proactively. So our research question was, does risk stratifying patients according to wraparound service needs increase referrals? And we're also interested in a secondary question here in this study was, if we are increasing referrals, how do we know we're referring to the right people or people who really want to be in these services? So we looked at this other outcome of, are patients who are referred, are they keeping their services? Are we getting better uptake by matching people to who they need to be referred to better? So we rolled this out in a pragmatic trial using a step wedge design. Eskenazi Health has 9 primary care clinics across the city. And so we rolled out our risk stratification tool 3 clinics at a time. We have our baseline data. We rolled out 3 clinics live. And then we waited 3 months and then rolled out 3 more clinics. And then we waited and rolled out our final tree. So for every single clinic, we have a pre-observation period. And through the step wedge approach, every single clinic is live, except for the last 3, has a comparator group to compare against. So we have pre-post and a comparison group for every single data set or for every single patient. What we did is our exposure was the risk stratification category for every service. And how do we do that? Well, Eskenazi just didn't want to know what is this score from 0 to 1 of a probability of a patient needing a service. What they want to know is, how do we make that more actionable? And they were using a variant of the old 80-20 rule in many of their decision-making processes. Was 80% of the population is low risk, 15% are what we're going to call a rising risk, and then the top 5% is the highest risk, right? And that's how we're going to decide who to focus on. It's really that top of the pyramid, highest risk. So what we do is we take our risk scores and plot them out. What you see here is a histogram of risk scores for the predicted probability of, I believe this is actually needing social workers. And then you see the line is the cumulative percent over time. And what we did is we scale it across. So we said, okay, at 80%, these risk scores are under this low risk category. We call them low risk. We then find the next 15% of the population, which gives us a rising risk category. And then our highest scores are in the rising risk overall. So we get the top 5% there. This is pretty important for 2 reasons. One, it scales the risks to the patient population itself. And then the other factor is we just can't tell everybody who has to Eskenazi who has a risk that they're high risk. That won't work. We would overwhelm the infrastructure capabilities of the health system in one day. Most patients at a safety net clinic have at least one social determinant of health need, and in some estimates, nearly everybody going through safety net providers has some risk or need. So we have to be able to scale it to find those at the highest risk, and this was our approach, so it's scaled against the population. But this will be our primary exposure, people who are rising risk, low risk, and high risk. So we have the risk stratification for each group is high, rising, low. We have then also same-day appointments, people who are left out of our machine learning algorithm because they are walk-ins, and then we have our control site, or they had no exposure available at that time. Our covariates, we're going to look at demographics, we're going to look at the location and comorbidity scores, and we analyze this using a GEE regression model. For each wraparound service, we're actually able to stratify out by referral type here. And the answer was kept appointments only for patients with referrals, and we actually have a non-equivalent dependent variable in there as well. Eskenazi Health has a general wellness program called Healthy Me that they refer to as well. It's not specific to anything, and it is not included in the risk prediction. So we use that as a non-equivalent or control-dependent variable that we did not expect to be influenced by our risk prediction algorithm. So here we have a forest plot of the odds of increase of a referral for each social determinant of health service. That's the numbers across the top by the level of exposure. And we'll point a few things out here to start with. So overall, the intervention was not associated with increased referrals to any service. If we just predicted out you should go see somebody, it didn't really change anything. However, our risk prediction was associated with increased referrals to the social workers. So when the risk prediction goes live, we see more referrals to our social workers across the entire set of patients. Importantly, at the end, when we look at our general health program, the one that was our control-dependent variable, we see no broad changes to that one as well. So there is something going on with the intervention going live that is changing specifically the social workers. And we also see that referrals on same-day appointments, generally when no score is available, we actually see referrals even become less likely. So a patient is a walk-in, they are actually less likely to have a referral during our intervention period. And this could be a workflow issue, or potentially that if it's a same-day appointment, it actually may be a more acute condition. We haven't been able to tease that out yet, but we see that right now. So overall, not an increase overall or for any specific referral type except for social workers. Now when we look specifically at once they were referred, were they more likely to keep their appointment? We see overall, we see a general increase in kept appointments once patients were referred to each service. This is true for social workers overall, dietitians, behavioral health. We see a whole bunch of things there. That last category 5, other social determinants health services, that's kind of our grab bag of medical legal partnership, pharmacy consultants, groups that are too small to model individually, so we have to lump them together. So the fact that it's kind of all over the map is not surprising because they're very diverse services. But again, we see overall general increase in it and even a little hint of dose response, but we don't want to oversell that point. And yet again, our control-dependent variable is not changing, so we feel very good about that as an external validity or as an internal validity control. So what do we take away from this? Well, automated risk stratification scores, we've been successfully delivering them to Eskenazi Health primary care clinics. The intervention has been associated with increased referrals to social workers. The intervention was also associated with increased rates of kept appointments in multiple social determinants of health services. And then we'd also talk about where we're going next. Next is you saw that we're delivering a report that stands outside of the electronic health record. It's an automated process, but it's still outside the EHR. Our current efforts right now, again with the support of Robert Johnson and the Sister for Action program, is integrating this scoring system into our Epic EHR, and we'll have it there as an on-demand, real-time score that will also be available for any patient, whether or not they're a scheduled appointment or not. And that's what we're currently working on as well. And with that, I will thank you all for the time, and I will turn back over the project or the slide share to my colleagues.
Great. Thank you, Dr. Vest. I'd like to go ahead and give Dr. Mays a few minutes to comment on the project and the subject.
Absolutely. Well, fantastic. Thank you so much, Josh, and congratulations to all your colleagues in Indiana for some really great work done here as part of the Systems for Action program. As many of you probably know who are attached to our S4A program at the Robert Wood Johnson Foundation, the Indiana team is one of the earliest teams to be a part of this program. It's one of our what we call collaborating research centers that's a part of the Systems for Action program. One of three centers that started really at the beginning of this program, helping us to really flesh out the research agenda and helping us really learn how to do multi-sector collaborative work, focused testing ways of connecting medical, social, and public health systems. And the work that Josh presented today, I think, gives it a really some excellent examples of the kinds of fruits that are now coming to bear from by thinking creatively about mechanisms for connecting health and social systems, and also thinking about how to integrate really rigorous research design and methodology and measurement strategies into this approach. The findings that Josh presented today are really kind of hit square on at some of the major problems that we're trying to solve through Systems for Action. Again, specifically, how can we better align the delivery of medical care with the delivery of public health and social services that can address social determinants of health? And the work that Indiana is doing in their center are really testing a variety of related mechanisms for aligning systems across those different sectors. The first study that you heard from today that the team published earlier last year in an excellent Health Affairs article, again looking at the effect of wraparound services provision through a co-located model on healthcare utilization and outcomes, I think certainly provides one of the strongest bits of evidence to date about the effects and the benefits of providing co-located wraparound services. For that particular topic, this is a strategy that many safety net healthcare providers have been using for some time. It's been a core element of the community health center model for a number of years, but we've just lacked strong evidence on what impact that element of practice has. And it's been again a potential mechanism for better aligning healthcare delivery with social services delivery, but we just have lacked strong evidence to help us understand how well it works. In today's environment of increasingly scarce resources and changes in payment systems and delivery system models, those kind of practices that aren't backed up by strong evidence are increasingly falling by the wayside. So this research is really timely in providing some strong evidence that this practice really does have some benefits for patients and for the larger healthcare, public health, and social service delivery systems that are also trying to better serve these populations. It also raises a number of other interesting questions that I know, many of which I know the Indiana team have identified and anticipated, and I know are thinking about how they might begin to tackle. And Josh mentioned a couple of those already. But again, looking at these different types of once we know that delivering wraparound services really does have an impact in helping to reduce potentially avoidable and expensive subsequent healthcare utilization, hospitalizations, and ED visits, the question becomes, well, what's the right mix of those wraparound services? And I think in this initial cut, the data were just too sparse to be able to tease out the differential effects of different combinations of wraparound services. That's clearly one logical place to take this research in the future. The other kind of question that research begs, at least in my mind, has to do with what population subgroups might benefit most from these kinds of wraparound services. And that's a question that Josh's second research topic he presented today begins to get at. In the first study, really the team is basically estimating the average effect of providing wraparound services on patients served in the safety net setting. But presumably within that, hidden in that average effect, there may be certain subgroups that benefit highly from those activities, and other subgroups that have no benefit perhaps. And so being able to disentangle some of those issues, some of those heterogeneous treatment effects would be an interesting line of the investigation going forward. And a third question that I think about when I reflect on this research, again focusing still on that first component Josh mentioned of the wraparound services study, has to do with then what triggers wraparound service use? How do patients and populations how are they funneled into wraparound services use? Is there a precipitating health event or health shock that leads patients down the pathway of being referred in for services? And understanding those kinds of precipitating events would be important, both to better understand the effects that the Indiana team is estimating around the effects of wraparound services, but also thinking about the topics that the team is exploring in that second study, looking at predictive modeling, what factors are likely to lead into to service use. I think the second study the Indiana team has undertaken in looking at ways of predicting need for wraparound services, and then testing a strategy of using those predictive analytics to stimulate referral and navigation into those services. That's really an excellent example, I think, of how to take research findings and begin thinking about how to move those findings into action in ways that can actually change how health and social service delivery systems interact and align. I think this really is one of our best examples. The Indiana team provides us with one of the best examples in the Systems for Action program of how to move research findings at stage one into a strategy for action and a way of testing a further system alignment strategy that is based on evidence. The predictive analytic model that Josh and his team has developed and positioning and embedding that into the electronic health record system, and then testing through a pragmatic trial how that system actually shapes service delivery and service alignment. Again, an excellent example of how to move findings from a stage one study into action in stage two, and then put a research design around the stage two process as well, and in order to test how that works. So this sequence of studies really provides all of us with some excellent examples of thinking about how to do action-oriented, rigorous but action-oriented research that's really aimed at producing findings that can result in tangible actions around how to align health and social systems. I think I'd also comment use my advantage of having a little more insight into what's happening in the Indiana Collaborating Research Center and having the benefit of observing all the work that this team has done over the last now 2.5 years or so since they've been a part of this program. A lot of the research that you've heard today focuses heavily on the Indiana's collaboration with the safety net healthcare system there in Indiana, the Eskenazi Healthcare system, hospital and its network of safety net clinics, and then looking at their capacity for linking with wraparound service providers, social service providers, and others. We didn't hear a lot about the public health sector in the work that Josh presented today, but I wanted to make sure that to give the team credit that they're also their work also strongly engages the public health system there in Indiana, and the public health system features prominently in the research and the system alignment strategies that this team has been testing. Partly Indiana takes advantage of some unique arrangements in Indiana and in Marion County, and that the county public health agency is also strongly connected to the safety net healthcare delivery system, Eskenazi system, and to the academic enterprise that the Indiana team is involved in. And so they're really leveraging, the team is leveraging those existing relationships to test the kind of alignment mechanisms that you heard about today. And I know that other work that they've conducted and other work that they've published on recently focuses squarely on the public health system interface that is an important part of the work in Indiana. Other work they've published on has tested some mechanisms for integrating public health nurses directly into interdisciplinary care teams that are activated to use the information that Indiana is generating to better meet health and social service needs of the populations being served through that system. So there's also, we just wanted to make sure that to give this team credit for the fact that their other work really strongly engages the public health sector in implementing system alignment strategies, including some of the information and technologies that were the subject of the research presented here today. So this is really excellent work. I want to also make sure that folks know that the Indiana team successfully competed late last year for a follow-on study and a follow-on scope of work through Robert Wood Johnson Foundation and the Systems for Action research program, and that work I know is beginning to move forward now. That partly will involve an even greater focus on using these existing mechanisms that have been talked about today and positioning them for even making even stronger connections between the safety net healthcare and public health system and other social service providers in the community. I think partly with a focus on providers that are systems that are specifically designed to serve children, and including education and school-based systems. So we're excited about the next generation of research that will be moving forward from the Indiana team based on this excellent work that we heard from today. So again, congratulations to the Indiana team, and I think we can. I think at this stage we've got time for questions and comments from our audience today. I think, Shauna, are you going to moderate that?
Yes, I will.
Great.
I want to thank you both for your contribution and insights, and encourage all of our attendees to type in your questions or comments in the chat box in your lower left-hand portion of your screen. We already have quite a few, so I'd like to get us started. The first one is, was the intervention just adding a risk score on the patient's electronic health record so the provider can see the risk score or referral recommendation? Dr. Vest, do you want to comment back? Okay.
Yeah, I will. So the intervention is, that generally is, right, providing the risk score. So it's Again, in the first phase, it was external to the EHR. It came as a separate standalone report that was delivered to all the staff for them to utilize. The only kind of intervention components came through. One was that, and then it was me and one of the population health nurses that works at Eskenazi Health went through to every single clinic's team meetings and introduced the purpose of the project, the tool, and whatnot. Described it, illustrated how it was accessible, showed it, provided guidance from that, and answered questions through feedback. It was not mandated to use. It was also not like forced referral decisions. It wasn't like true clinical decision support that generated automated referrals on that front. Everybody was still left to provider autonomy and their own choices.
Okay, great. Thank you. We do have another one here. It was, how were the primary care clinicians advised to use the risk score in assisting their referral decisions? And a follow-up to that is, any data on whether and how the clinicians made use of the risk score?
Yeah, so we haven't followed up with the providers yet on their usage. We've gotten feedback from, so first I'll answer the second part first. We've gotten feedback on usage from providers like social workers and dietitians on how they use it and how they would like to better see information, and that's going into our new revision that we're working on currently. The way it was described was to providers was, this is an additional data point. It's an opportunity to identify people who are potentially high risk before they become challenges or before those risks manifest in complications to care delivery. So we pushed it mostly as, yes, this is about looking prospectively and using the data as additional data support to help your decision making. Again, we are, both us and our clinical partners, were not interested in replacing clinical judgment and clinical decision making. We were looking as an augmentation to what was going on.
Okay, great. Let's see. It looks like we do still have some questions. Can you elaborate on how the risk score was calculated? An algorithm of the electronic health record plus the claim plus the neighborhood data can generate individual risk score of the social determinant of health. So could you please give some more details?
Yeah, so again, I want to be clear, we are not predicting need of the social determinant, because you would actually have to be able to go out and assess and measure that and define it for a population and then use that to build your prediction algorithms. We opted to go for who was getting services that address those social determinants and behavioral factors. So what we predict specifically is who needs or who is at risk for a referral to one of those services. So we're actually moving straight to the action item of who should be getting those services. So yes, many people who are not included as high risk or rising risk, or even in our algorithms, many of them have social determinants of health needs. That's unquestionable. What we're predicting is, given these data sources and what we know, effectively, how much do you look like somebody else who has been previously sent or referred to a social worker? Or how much do you look like somebody else who has been to the dietitian? That is how we built our machine learning algorithm, to give us a hard outcome which we could use in modeling.
Okay, this is actually a direct follow-up to that. Harold Pollock from the University of Chicago has a specific question for you, Dr. Vest, on any special sensitivities or anxieties among stakeholders regarding the use of the machine learning algorithms. He said that they sometimes encounter community concerns, of course, particularly in a mental health or criminal justice context. So if you want to comment back to him, that'd be great.
Yeah, so we are totally sensitive and very much concerned with the ethics and the privacy and the concerns and the sensitivities around both using to use a buzzword, big data and machine learning algorithms and black boxes, right? That is a significant concern. The literature already says that some patients will not like answering questions and screening questionnaires around certain social determinants, right? So we don't ask that. That's off. We're also using data that's already been collected and already in existence. So we're already doing something that's leveraging a consented process to begin with. Lastly, we are identifying, need for a referral to a service. We are coming up to the point where we suggest that this patient could be at risk for referral. The choice for referral is not taken away from the provider. The provider has their clinical judgment and can go through and have the conversation with the patient before making the referrals. So all of that's in hand. So we feel much more comfortable with not simply labeling anybody by having a particular need, but by saying, there's a reason why you could go. Now, the truth is, as we look across the literature, the need for social workers, the need for dietitians, the need for behavioral health is fairly ubiquitous. So most patients would benefit from any of these services to begin with. But we definitely are very much attuned to the fact that, and this may be related to this question, we know that several organizations are exploiting these types of data now to identify how to change reimbursement rates or necessarily change premiums or things like that to address. That's totally not interested from us. We are interested in, so how do we better efficiently and effectively get the patients to the care they need?
All right, great. Thank you so much. I see we still have a few minutes, so I just actually had a question maybe you can comment on myself. I heard Glenn kind of touching on the use of this for subpopulations, and I actually had a note here where I was curious about your thoughts on using the risk stratification tool on a national level or a subpopulation level, and if anything was unique about the Eskenazi Health system that you think that this may have trouble applying across the board to other clinics and in future use.
Yeah, so I think anytime you do risk stratification like this, and it goes, the process and the concept and the data are generally portable. Now, data is idiosyncratic. The sources we're using can largely be existing in other places. We do have the benefit of having the world's oldest and possibly largest, although it may have been surpassed now, health information exchange in operation. But many other places have access to interoperable data from multi-institutions, whether it's through a vendor-based relationship or community health information exchange. So those things exist. What machine learning algorithms would have to be reparameterized for every population. As you can imagine, the needs and a risk of a safety net population in an urban core is very different than a primary private payer suburban population. So the models would have to be recalibrated and fixed to fit every location, and then of course rescaled against the population. But this approach can be ported elsewhere. I definitely do agree there is a particular interest in ours too, knowing what kind of mix of services is correct. We have a current, hopefully, knock on wood, to be accepted Academy Health abstract that actually goes through this using a market basket analysis approach to identify what mix of services patients are getting when they get referred to these services, to understand exactly what things co-locate. So as you can imagine, family social support and mental health issues go together. Financial instability and housing issues co-occur quite frequently as well. So we're trying to explore and get deeper into those things as well.
Okay, great. Yes, thanks for your comments. I can see that the future of this project is quite strong, so I really appreciate you commenting back on that. It looks like we're almost out of time, and you have answered all the questions from our attendees. So I want to give you a big thanks, and also Dr. Mays a big thanks. And I can go ahead and just wrap up today's webinar by going ahead and presenting a short agenda for our upcoming Research in Progress webinars. Our next webinar will be January 23rd at 12 noon. where we'll hear from Daniel O'Connell on implementing a culture of health among Delaware's probation population. And we like to go ahead and give some acknowledgements. The Systems for Action program is a national program from the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky here in Lexington, Kentucky. We hope that you have enjoyed your time, and we thank you for attending today's webinar. We hope that you can join us on upcoming webinars on January the 23rd. Thank you very much. We will go ahead and end just a few minutes early. Have a great day.